العفو أستاذ إياد، دزيت لحضرتك ريكورد، وصلك الطلب؟
نعم.
دزيت لحضرتك ريكورد، وصلك الطلب؟
ماكو طلب، بس خل اشوف، خاف ماكو شيء. المفروض هو بدون طلب يعني انت تسجل.
والله كاتب لي العفو دكتور. Please request recording permission from the meeting host.
خل اشوف اذا اكو طلب انا
أي
أجاوب.
نعم. نعم.
هسه ما طالع عندي اي طلب.
ماشي أستاذ.
محمد ما طالع عندي مع الاسف.
نعم أستاذ. أي ما أعرف، يجوز اكو فد مشكلة أو شيء.
المحاضرة الجاية احاول اتاكد انه الريكورد بدون طلب، يعني يصير مباشرة.
إن شاء الله أستاذ.
اوكي يعني shall we
إن
start?
شاء الله. إن شاء الله. إن شاء الله.
Today we are talking about second part of important presentation, which is blood transfusion. And in this part, we will focus on complications of blood transfusion and the important type of blood transfusion, which is autologous blood transfusion. And one of important parameter for the anesthetist personality is the ability for good communication skill. So with each presentation, I'm trying to take certain aspect of the communication skill. And in this presentation, I want to ask about victory or illusion. In Arabic, Nasr am Awham. For this statement, anyone can give me a comment regarding this statement: victory or illusion, Nasr am Awham. Zina, إذا عندك فد idea about this statement.
العفو أستاذ، أنا بمدينة الطبخة فرفد شوية الصوت مو واضح.
أوكي. علي ناظم.
الو. نعم استاذ وارد.
عندك فد شيء علي ناظم على هاي
يعني عندي
الستيتمنت؟
عندي محاضرة على النت فاتحة هسه سويت، بس ماكو صوت، يعني سويت ميوت.
Okay. Any one of you يعني has idea about this statement, victory or illusion? What does it mean, this statement?
العفو دكتور.
تفضل.
يعني ممكن ناخذها بالوضع اللي احنا بيه، يعني مثلا انه يعني كدراسه وكبورد وهاي، يعني انه مرات الواحد تجي له حالات يجوز يأس، يقول انه انا ما راح اقدر اكمل او شيء او صعب الموضوع، بس انه هذا كله اوهام. يعني بالاخير احنا ان شاء الله راح نقدر نعبرها هاي الكم سنه ونحقق اللي احنا نريده، يعني او اللي نتمناه كنا.
اوكي شكرا. اي واحد عنده بعد فد كومنت for this statement؟ اوكي، انا راح اوضح بعض الامور. احنا بحاجه ان نعرف what does it mean victory for any behavior of ourselves. فاذا ناخذ فد مثل بسيط، انه لو اكو سارق يعني يسرق فد مبلغ من المال من شخص، او يسرقه من مصرف مثلا، بالحقيقه يعني يعتبر victory، يعتبر نصر. بس احنا اذا ناخذ from another aspect of view، وهي يطلع بالعكس هذا مو نصر بس هو خساره. اذا ناخذ الدوام مالتنا مثلا، قد واحد أثناء الدوام ممكن أنه مثلا ينسق مع المسؤولين وممكن ما يداوم، فهو قد يعتبر هذا نصب، يعني حقق قد نصب، يعني حقق قد مكسب أنه ما يداوم، بينما بالحقيقة هو أخسر الخاسرين، لأنه التعلم الحقيقي، تعلم السكيلز، تعلم البيهيفيرز هو يجي from a practical point of view. كل الصعب واحد قاعد ببيته ويتعلم بدون أنه يكون practically on the ground. فلذلك احنا دائما نقول we have to define the victory for each behavior حتى نعرف احنا in a real actual victory or it is just illusion. فمن هذا الكلام اكو بعض العبارات العربية المشهورة ممكن انه support this statement. مثلا واحدة من العبارات تقول ما ظفر من ظفر الإثم به، يعني هو قد يكون سرق فشي مكيف، يعني محصل ظفر نصر، بس هو من جهة ثانية ظفر الإثم به، ممكن لونج تيرم تكون هذا وبال عليه هذا الظفر. أو بعض العبارات الأخرى تقول الغالب بالشر مغلوب، يعني ممكن الإنسان من خلال الأجريسيفنس، من خلال الإجرام، ممكن أن يغلب في بعض الأحيان، بس هو بالحقيقة مغلوب. In today's presentation, we will answer the following questions. First questions regarding the massive blood transfusion. What is the scientific approach to give fresh frozen plasma and platelet in relation to packed RBC or whole blood? Do you recommend prophylactic calcium to prevent hypocalcemia? Do you recommend the prophylactic sodium bicarb to prevent metabolic acidosis? Patient with acute hemolytic transfusion reaction and still needs blood, what do you choose? Which type of blood group? And regarding autologous blood transfusion, are all patients suitable for autologous blood transfusion? يعني احنا كلياتهم نقدر نسوي لهم autologous blood transfusion. What is the estimated blood volume can be taken in acute normobulimic hemodilution? What's the maximum allowable blood loss? يعني احنا بالعملية ايش قد مسموح انه المريض ينزف بدون ان ننطي blood? What are the physiological compensatory mechanisms to maintain oxygenation in anemic patient? Does the O2 consumption be decreased in response to decreased delivery of O2 or O2 delivery? All these questions will be answered throughout this presentation. And please, if one of these questions will not be answered, just allow me to answer any of these questions at the end of a presentation. Massive blood transfusion. To know the massive blood transfusion and diagnose it, we have to define massive blood transfusion. And in this slide, there are 3 definitions of massive blood transfusion. And any of these definitions can be applied. We diagnose the case as a case of massive blood transfusion. The first one is the transfusion of half of a blood volume within 3 hours. Yani for adult, about 5 units, about 2.5 liters per 3 hours. And this definition has been updated maybe 3 years ago. Before 3 years, the definition was in 1 hour rather than 3 hours. The second definition, the transfusion of an amount equal to or more than 1 blood volume within 24 hours. And the third one, transfusion of blood in a rate of 150 ml per minute. So any of these definitions can be applied. We regarded the case as a case of massive blood transfusion. So it is not necessary to depend on single definition. Actually, any of these definitions can be applied as a case of massive blood transfusion. The important issue, and this is why we differentiate massive blood transfusion from other usual form of a blood transfusion, actually because of massive blood transfusion may be related to specific types of complications. And these types, we are talking about first, dilution of a platelet. Cord blood has no functional platelets after 48 hours, after 2 days. And after 8 to 10 units of blood transfusion, thrombocytopenia will usually seen. The bleeding due to slightly low platelet is uncommon. Therefore, routine administration of platelet after certain amount of blood transfusion is unnecessary. We need regular monitoring of a platelet count, which is more important than platelet as a prophylactic or as a routine administration. The platelet transfusion may be required if platelet count less than 100,000 with a continuous bleeding or the patient scheduled for surgical intervention. So according to this slide statements, we take answer of one of the questions already introduced, that the administration of platelet is not necessary, and we depend on the monitoring by lab investigation of platelet count, and the patient may be not required for platelet unless the patient wants to bleed or surgical intervention. And شباب اكو اصوات بدها تجي من يمكم، فيا ريت تسدون المايك. The second complication, dilution of coagulation factors. As you know, stored whole blood less than 14 days has adequate levels of most coagulation factor for hemostasis, but most likely decreased factor within this duration are fibrinogen, which is factor 1, and factor 5. What about factor 8, which is also of short half-life duration? Factor 8 probably stored in endothelial cell and released during stress. And you know, surgery is a stress. The use of stored blood of more than 14 days, in this statement, we were talking about less than 14 days. Here, we are talking about more than 14 days. Or whole blood or packed RBC in optimal additive solution may require replacement of coagulation factors with a fresh frozen plasma if necessary. If necessary means depend on monitoring and lab investigation. What is the scientific approach to give fresh frozen plasma and the platelet in relation to packed RBC or whole blood. منتظر مجيد أو ماجد.
نعم أستاذ.
يلا ما.
على ال ASA guideline يعني.
نعم.
نحتاج مثلا urgent reversal مالت الوافرين ثيرابي، أو عندنا coagulation factor يحتاج له correction يعني deficiency اللي هو 5 أو 8 اللي موجودة بالفريش فروزن بلازما. أيضا إذا عندنا microvascular bleeding، إذا كان شو اسمه بروثرومبين تايم باريشال تايم أكثر من 1.5 النورمال.
أوكي. عمر صلاح. Amar, we are talking about the placement of fresh frozen plasma and the platelet during blood transfusion. What is the scientific approach during massive blood transfusion?
scientific approach generally according to investigation إذا كانت موجودة عندي facility. The investigation facility not available يعني بالoperation room أنا نعتمد يعني على expected blood. إذا كانت الكيس emergency أو كانت elective. في حالة الإمرجنسي استبعد نطبق البروتوكول مال 111.
نعم.
one bucket RBC one fresh frozen plasma one platelet. بس إذا كانت الكيس elective وما عندي facility حتى أقيم investigation عفوا، فإنه بعد كل 3 إلى 5 bucket RBC إنه ممكن أنطي platelet fresh frozen plasma.
Okay, right. Thank you. So this is the scientific approach to depend on investigations and the platelet count, while if the case is with severe blood loss and massive blood transfusion, we cannot wait for investigation. Here we have actually 2 approaches. First approach, if we expect severe bleeding that will reach up to whole blood within hours, هنا ايش راح نسوي؟ راح نعطي in a ratio of 1-1-1. 1 packed RBC, 1 platelet, 1 fresh frozen plasma. If the case is a massive blood transfusion, but not in so severe massive blood loss, and we have no facility of investigation the platelet count or concentration of clotting factor, here we can depend on the giving of fresh frozen plasma after about 3 units of packed RBC and the platelet after about 5 units of packed RBC. The third complication is hypothermia, and hypothermia is common during massive blood transfusion, and the hypothermia defined as a core body temperature less than 35 centigrade. It is associated with large volumes of cold fluid transfusion. It may result in cardiac irregularities, in particular ventricular fibrillation. So it is serious complication and may lead to morbidity and mortality. Therefore, the use of blood warmer is important, and we have several types of blood warmers. Some of these warmer, electrical warmer that can be competent during massive blood transfusion. The fourth complication is an excess of citrate. You know, citrate included within the preservative that keep the blood from coagulation, regarded as anticoagulant, and also hypocalcemia. Citrate can act on the patient's plasma-free ionized calcium and magnesium. and result in transient hypocalcemia and hypomagnesemia. And here we have important complication. We call it torsada di pointi. Torsada di pointi. Muhammad Jode, Muhammad Talib. What is the torsada di pointi?
العفو هي polymorphic ventricular arrhythmia that results from hypomagnesemia.
Good, good. So when we are aware about this complication, if we face this complication during massive blood transfusion, we can اكو اصوات يا ريت لو تسدون المايكات شباب. ستريبتوكسيسيتي
بس ايه حتعب الصوت والله.
شباب يا ريت تسدون المايكات مباشرة. Toxicity occur with extremely rapid transfusion, 100 ml per minute, 1 unit every 5 minutes. In a premature infant having exchange transfusion with the blood stored in citrate. So citrate toxicity in these two important events. And it causes metabolic acidosis because the citrate is acid, so causes metabolic acidosis in early time and followed by alkalosis when the citrate metabolized to bicarb. So do you recommend the prophylactic calcium to prevent hypocalcemia? ظفار. ظفار.
نعم.
ظفار, do you recommend prophylactic calcium administration to prevent hypocalcemia?
No.
Why? Okay, Dhafar, no problem. Actually, your answer is correct. No need for prophylactic calcium to prevent hypocalcemia. This is a transient hypocalcemia and will relieve soon after a while. And we can depend on measuring of calcium concentration. And according to the results of calcium concentration, calcium in the serum calcium, we can use calcium or not. So no need for the prophylactic administration of calcium. The fifth complication is acid-base disturbances.
العفو استاذ اياد، عندي سؤال على هذا السلايد بالنسبه للهايبوكالسيميا. يعني اكو العفو استاذ فد مثلا النومات معينه من البلاد انه لازم مثلا ننطي بعدها هايبوكالسيميا. احنا بالنسبه لنا يعني قبل من كنا طلاب انه نون ساينتفك ابروتش، كانوا قبل يعني مثلا يقولون انه بعد ال 3 بوينت او 4 بوينت بلاد انه لازم ننطي كالسيوم. اكو ريليشن العفو بين انه الاماونت مال البلاد والتايم اللي ننطي من يعني خلال البلاد انه لازم بعدها ننطي كالسيوم بدون ما يعني نسوي سيروم كالسيوم.
Okay, the approach you have mentioned used by many physicians and the scientific approach to give calcium according to calcium level. But if the calcium level not available, yani you cannot catch the result of investigation of serum calcium, you can depend on what you have mentioned of giving calcium after about 3 to 4 units of blood. Acid-base disturbances. Lactic acid in stored packed RBC, about 30 to 40 millimole per liter. And also we have citrate. So now we have two acids, citrate and lactic acid. Both of them metabolize to bicarbonate. So metabolic acidosis early, followed by alkalosis when citrate metabolized to bicarb. According to this statement, that the metabolic acidosis is a transient and followed by alkalosis, this question, do you recommend the prophylactic sodium bicarb to prevent metabolic acidosis? Actually, no need for prophylactic sodium bicarb to prevent metabolic acidosis. It is just a transient complication and will soon convert it to metabolic alkalosis rather than acidosis. Hyperkalemia can be caused by loss of intracellular potassium from RBCs during storage. After hemolysis of RBCs will release the intracellular potassium to the extracellular fluid. Or during the infusion of intracellular potassium depleted RBC blood components such as washed RBC or frozen washed RBC. It occurs in extremely rapid transfusion, which is about 100 ml per minute, 1 unit every 5 minutes, and may lead to, in such a rate of infusion, may lead to hyperkalemia and hypocalcemia. And if the patient cannot restore perfusion and reverse acidosis to alkalosis that shift potassium to cells. So in such complication, hyperkalemia, we have to manage hypokalemia. How do you manage hyperkalemia? حسين عبد القادر. حسين عبد القادر. How do you manage hyperkalemia? حسين ما موجود. أمير. Okay. The management of hyperkalemia starting by giving
antagonized الكالسيوم.
الأستاذ.
اوكي.
استاذ هو احنا نعتمد على اذا كان الهايبركاليميا لايف ثريتنينج او نون لايف ثريتنينج، خاصه اذا صار عندنا يعني بالاي سي جي تشينجز، مثلا صار عندنا اريثميا اللي هي التشينجز اللي راح تكون مثلا البرود بي ويف وبيكت تي ويف ووايدند كيو ار اس. فانا اعتمد اذا كانت اكو يعني لايف ثريتنينج او نون لايف ثريتنينج، بهالحاله راح يعني اسوي مانجمنت للهايبركاليميا عن طريق انطي كالسيوم وانسولين، لانه الانسولين راح يقلل لنا تقريبا 1 من الليفل من البوتاسيوم. ف يعني هي
you are treating hyperkalemia by giving calcium gluconate. Do you think that
لا مو كالسيوم جلوكانات، انطي كالسيوم كلورايد، لانه هو يحتوي يعني contain 3 times of calcium than gluconate.
Okay, whatever. You are giving calcium. Do you think that the giving of calcium would decrease the potassium level?
لا هو ما راح يقلل الكالسيوم ليفل، هو راح يقلل لنا الكاردياك اكسايتمنت ثريشولد، بس ما راح ياثر على البوتاسيوم ليفل.
So it is very important and essential in the management of hyperkalemia and the starting of management by giving of calcium, the starting of management just to prevent the important catastrophic complication of heart, cardiac standstill, and then after that we can giving the medications or agents that decrease the potassium level. And you have mentioned one of these, which is the insulin, and also we can use bicarb to decrease. And there is in the lines of management also sympathetic agonist. And I'm talking now about the management of hyperkalemia. And if we talk generally, apart from massive blood transfusion, there is also in the lines of management, last line of management, the dialysis, hemodialysis. And also there is another thing in the mild hyperkalemia, not during massive blood transfusion, in the mild hyperkalemia, the use of resin, which is chelating agent, and that can decrease the potassium level. Other complications of massive blood transfusion, fluid overload, which is very important because we are talking about one of definitions more than 150 ml per minute. And in such situation, rapid blood transfusion, there increase in the incidence of thrombosis and air embolism. And there is high autoaffinity blood due to decrease in 2,3-DPG, and this can result in tissue hypoxia. We were talking about complications of massive blood transfusion. And now we will talk about the complications of blood transfusion in general. When I say in general, means any of these complications can occur not necessarily after infusion of large amount of blood, and maybe happened after some of these complications after drops of blood. These complications can be classified into two important groups of complications. First one, immunological complication, and second one, non-immunological complications. And I started by non-immunological complications. This is number 2, non-immunological complication, because most of non-immunological complications are similar to those of complications of massive blood transfusion. If you look at these complications, the same complications have been mentioned during massive blood transfusion complication. And in addition to these, we add the infection with HIV, cytomegalovirus, hepatitis, and bacterial infections. And the incidence of the virus transmission for hepatitis B, about 1 per 63,000. And for C, about 1 per 100,000. And for HIV, about 1 per 450 to 600,000. And for bacterial reaction, maybe from RBCs or platelets. From RBCs, about 1 per 30,000, and for platelets, 1 per 2,000. Now we are talking about a group of blood transfusion complications, which is immunological complications. And immunological means there is antigen-antibody reaction. When we say immunological, means there is antigen-antibody reaction. This immunological complication can be subclassified into hemolytic and non-hemolytic. The hemolytic reaction, first, acute hemolytic transfusion reaction. So now the complication, immunological and non-immunological. The immunological, either hemolytic or non-hemolytic. The hemolytic, acute hemolytic transfusion reaction. First type, it is immediate and intravascular. Happen intravascular and immediate due to ABO incompatibility, and the hemolysis of donor RBCs often lead to acute renal failure, DIC, and may lead to death. ABO incompatibility is the second only to Trolley of the 3 leading causes of transfusion reaction. We have 3 leading causes of death due to transfusion. First one, due to Trolley. Second one, ABO incompatibility means acute hemolytic transfusion reaction. And the third one, we will talk about the third one after few slides. Acute hemolytic transfusion reaction, when incompatible blood is given, antibodies and complement in the recipient plasma attack the antigen on the donor RBCs, result in hemolysis. The antigen-antibody complex activate the Hagman factor, which is actually factor number 12, which act on kinase system to produce bradykinin. And bradykinin increases capillary permeability and dilate arterioles, both of which causes hypotension. The end result of activation of Hagman factor and the production of bradykinin is the complication of hypotension. And severe hypotension may be presented as a shock status. The activation, another activation is that of complement system, result in the release of histamine and serotonin from mast cell, resulting in bronchospasm. In a previous slide, we were facing hypotension, and according to this attack of mast cell, the result is bronchospasm. Now both respiratory and cardiovascular systems are affected. About 30 to 50% of patients develop DIC. The renal damage occurs for several reasons in the acute hemolytic transfusion reaction. First, blood flow is reduced because of hypotension and renal vasoconstriction. Second, the free hemoglobin can cause a mechanical obstruction, and if DIC occurs, the fibrin thrombi can be deposited in the renal vasculature. Both of these reasons lead to renal damage and may result in renal failure. The signs and symptoms in general means not in anesthetized patient. In general, fever, chills, nausea and vomiting, diarrhea, rigors, hypotension, flushed appearance, chest pain and back pain, dyspnea may lead to respiratory failure. Patient is restless and has a headache, hemoglobinuria, and possible diffused bleeding. These signs and symptoms in non-anesthetized patient. Many of these signs and symptoms will be masked by general anesthesia, so the following signs may give clues that a transfusion reaction has occurred. When there is an increase in airway pressure or decrease in O2 saturation, unexplained hypotension, hemoglobinuria, and diffused bleeding. A reasonable index of suspicion should be maintained while administration of blood product under GA. معناها احنا من نعطي blood لازم نبقى يعني aware about the possibility of such complication, because most of signs and symptoms masked by GA. So to be aware and observe these important signs during anesthesia. Management of acute hemolytic transfusion reaction. If a reaction is suspected, the transfusion should be stopped, and the identity of the patient and labeling of the blood rechecked. In the previous presentation, I have said that this complication only occur by a mistake. يعني احنا ماكو واحد بينا يجي ينطي blood group A to patient with blood group B. ما تصير. بس هي by a mistake. The mistake may be in the lab, maybe in the ward. Several mistakes can lead to such complication. فلذلك هنا ايش راح نحتاج؟ راح نحتاج نسوي rechecking. And the management has four important objectives. Maintenance of systemic blood pressure, because we already said there is circulatory failure. Maintenance of normal ventilation, because there is a bronchospasm. Preservation of renal function to prevent or manage renal failure or impairment. Prevention of DIC. In the management, we need lab tests and should include a repeat cross-match and direct antiglobulin Coombs test. The direct antiglobulin test is the definitive test for an acute hemolytic transfusion reaction. It examines recipient RBCs for the presence of surface immunoglobulin and complement. Patient serum is also examined for antibodies that react with the donor cell. The treatment started by take samples of recipient and donor blood for analysis. O2 and main require controlled ventilation. جزء واحد منكم يسأل يقول هو already the patient anesthetized. Here, if the patient not anesthetized. IV fluid. And the cornerstone in the management is the giving of adrenaline IV, 0.5 to 1 ml of 1 per 10,000. لما نقول 1 per 10,000 هاي الأمبولة تجي على شكل 10 ml. 10 mils مجموعهن 1 ملغ، يعني كل مل ب 100 مايكروغرام، فاحنا ننطي 50 to 100 microgram 0.5 إلى 1 ml of adrenaline every 3 to 5 minutes as required and may followed by infusion. ممكن أنه بعدها نحتاج إلى infusion. Antihistamine chlorpheniramine 20 to 20 milligram, hydrocortisone 1 to 500 milligram IV, treatment of bronchospasm, and you know the lines of management of patient with bronchospasm, including the beta agonist. Sodium bicarb may be required according to blood gas analysis, and in the last 4 to 5 years, the development of CRRT improved widely the success rate from this important complication. Mean the referral of patient to ICU for continuous renal replacement therapy. The treatment of renal ischemia by giving crystalloid, diuretic azafurosemide 20 milligram, and alkalinization of urine with sodium bicarb. The prevention and management of DIC, this is a very big topic. We will talk about in details in the specific presentation later. Now, patient with acute hemolytic transfusion reaction and still needs the blood. What do you choose? First, we try our best to avoid further blood transfusion unless absolutely necessary. Absolutely necessary. And if the patient absolutely necessary, better to give O negative packed RBCs with universal donor to decrease the incidence of the further complication. We were talking about acute hemolytic transfusion reaction. Any question? Okay. Now, delayed hemolytic transfusion reaction. For revision, we have immunological and non-immunological complication. The immunological complication, either hemolytic or non-hemolytic. The hemolytic, we have acute immediate and delayed. This is the delayed hemolytic transfusion reaction. It is delayed because occur after 7 to 10 days. And this occur extravascular, while the acute hemolytic transfusion reaction occur intravascular. Acute hemolytic transfusion reaction happen immediate, here after 7 to 10 days. And this occur due to reaction to minor blood group other than ABO. Already in the previous presentation, we have mentioned that we have several antigens, several systems of the blood, RBCs, and the ABO is the common system, while we have other types of antigens, and this complication may occur due to reaction to minor blood group other than ABO. This reaction occurs when the donor RBCs have an antigen to which the recipient has been previously exposed by transfusion or pregnancy. However, over time, the antibodies fall to level too low to be detected by compatibility testing. With this new exposure, the patient produces more antibody that eventually lyses the foreign RBCs. The symptom of delayed hemolytic transfusion reaction, low-grade fever, increased bilirubin with or without jaundice, reduction in hemoglobin, and diagnosis confirmed by Coombs test. The reaction is self-limiting and the clinical manifestations resolve as transfused cells are removed. So the treatment of these complications is conservative treatment, conservative. It is not sophisticated or critical complication. Now we will talk about second group of immunological complication, which is non-hemolytic reaction. The reaction in this group of complications الشباب أرجو أنه تطفون المايكات لأن أكو أصوات، هاي الأصوات تأثر عليكم وتأثر على اللي راح يسمعون المحاضرة باي ريكوردينج، فكليتكم من يمكم طفوا المايكات. In non-hemolytic reaction, the reaction occur between either recipient antibody in response to previous transfusion or pregnancy with white BC, platelet, or of donor. بس اخوان اعزائي، يعني انا من دا اقول طفوا المايكات وواحد ما يطفيها، يعني what does it mean؟ يعني معناها هو فاتح اللابتوب بس مو يمه ما دا يسمعني. فانتم كليتكم ما مجبورين على الحضور، اللي ما يريد يحضر يعني فري، لان هي المحاضره راح تجيكم على شكل ريكوردز برزنتيشن، فماكو داعي يعني يفتح اللابتوب مالته او الموبايل على اساس هو موجود بالمحاضره بس هو ما دا يسمعني. والا انا شلون افسر هسه دا اقول طفوا المايكات وما يطفي المايك؟ يعني شلون افسر؟ الا اذا ما دا يسمعني، يعني هو مو يم اللابتوب ولا يم الموبايل. بالمقابل دا ياثر على المحاضره مالتنا، عليكم دا ياثر، وممكن ياثر على الناس اللي راح تسمع المحاضره بعدين. فبليز اي واحد عنده شغل تعبان ما مجبور نهائيا انه يحضر المحاضره اونلاين ولا يحاسب، اصلا ما يحاسب. راح تجي المحاضره ريكوردد ويسمعها براحته، بس لا يشوش علينا. من دا يطلع هذا الصوت دا يشوش علينا كليتنا. يعني المحاضره السابقه كانت هوايه اهدأ من محاضره اليوم. Reaction in non-hemolytic reaction occur between first recipient antibody, this recipient antibody in response to previous transfusion or pregnancy, with white blood cell, platelets, or plasma protein. Now we are talking about non-hemolytic reaction, non-hemolytic reaction. And we have 4 types of this non-hemolytic reaction. First, febrile reaction, which is most common, about 1 to 3%. Mild allergic reaction, anaphylactic reaction. And fourth one, transfusion-related acute lung injury, يسموها Trolley. And if you remember, when I was talking about the mortality, the causes of death due to transfusion, I mentioned that the Trolley is the first cause of death due to blood transfusion. And the second one was acute hemolytic transfusion reaction. And I already said there are 3 causes of death due to blood transfusion. The third cause is anaphylactic reaction. Anaphylactic reaction. Now we have 3 causes of death due to blood transfusion. First one, Trolley, transfusion-related acute lung injury. Second, acute hemolytic transfusion reaction. And third, anaphylactic reaction. Febrile reaction, patients who receive multiple transfusions often develop antibodies to the HLA antigens on the passenger leukocytes. During subsequent RBC transfusions, febrile reactions may occur as a result of antibody attack on donor leukocytes. The response occurs in 1 to 2% of all RBCs transfused. It is high percent, but it is fortunately only mild complication. Temperature increase more than 1 degree centigrade within 4 hours, that resolves within 48 hours. The second type, minor allergic reaction. Allergic reactions to proteins in the donor plasma can cause urticarial reaction in 0.5% of all transfusions. The reaction is almost always associated with fresh frozen plasma administration. That is to say, mainly this type of complication associated mainly with fresh frozen plasma administration. The patient may have itching, swelling, and rash as a result of histamine release and the treatment by antihistamine diphenhydramine. The third type is anaphylactic reactions. This occurs in patients with hereditary immunoglobulin A deficiency who have been sensitized by previous transfusion or pregnancy and are exposed to blood with foreign immunoglobulin A protein. Reaction include dyspnea, bronchospasm, because this is anaphylactic, serious complication. Anaphylactic reaction is a serious complication and should be treated as soon as possible because anaphylaxis may lead to bronchospasm, hypotension, laryngeal edema, chest pain, and shock. The treatment is with epinephrine. Epinephrine, already I talked about the regime of giving epinephrine and methylprednisolone and other measures used in the management of anaphylaxis. I mean, in the management of anaphylaxis for any reasons, even anaphylaxis to drug. The same management here can be applied. Transfusion-related acute lung injury, Trolley, is a non-cardiogenic form of pulmonary edema associated with blood product administration. Pulmonary edema, but not cardiogenic pulmonary edema, is associated with administration of all blood products, but occur most frequently with packed RBCs, fresh frozen plasma, and platelets. The incidence is 1 to 5,000 units transfused, and the Trolley has a mortality of 5 to 8%. The mortality of Trolley, if after occurrence of Trolley, is 5 to 8%. يعني من كل 100 واحد يصيرون Trolley, 5 to 8 persons of these 100 patients died. Trolley was the most common cause of transfusion-related death from 2001 to 2003. Most common cause of transfusion death. Trolley occurs when agents present in the plasma phase of donor blood activate leukocyte in the host and in the recipient. Those agents are usually anti-leukocyte antibodies in donor blood formed as a result of a previous transfusion or pregnancy. Trolley usually requires pre-existing conditions such as sepsis, trauma, or surgery. So when we are facing Trolley, because we are anesthetist and mostly we are giving blood during anesthesia and surgery. The clinical features of Trolley, similar to adult respiratory distress syndrome, ARDS. Symptoms usually begin within 6 hours after the transfusion and often more rapidly. The patient develops dyspnea, cyanosis, chills, fever, hypotension, and non-cardiogenic pulmonary edema. The chest X-ray reveals bilateral infiltrates. Severe pulmonary insufficiency can develop. The management mainly is supportive, and the transfusion should be stopped if the reaction is recognized in time. The patient should receive oxygen and ventilatory support as necessary, usually with low tidal volume strategy. Here in this table, all the transfusion reaction complications and the causes of these complications and the frequency of these complications. And here, the same regarding the incidence of the transfusion reactions, and you may find some differences in the incidences between several papers and textbooks, and this is accepted because there are many variations regarding the incidences of these complications. Now, the second part of the lecture, which is autologous blood transfusion. And before we talk about autologous blood transfusion, if you have any question about the complication of blood transfusion, I am waiting for any question.
العفو استاذ، بس عندي سؤال بخصوص الترالي. يعني بالترالي البلاد مال الدونر، هو الدونر اوريدي كان متعرض اكسبوجر صاير عنده للانتيجين؟
You mean this slide?
اي بالضبط.
This
اي يعني قصدي الدونر هو اوريدي كان متعرض اما خلال بريجننسي او بلاد ترانسفيوجن، بعدين اخذوا منه بلاد وانطوا للريسيبيانت.
Look. Trolley occur when agents present in the plasma phase of donor blood activate leukocyte in the host. Yani this agent from the donor activate leukocyte in the host, اللي هو recipient.
واضح.
Those agents are usually anti-leukocyte antibodies in the donor blood formed as a result of a previous transfusion or pregnancy. Where? In the donor.
Donor.
Yes.
Okay, thank you.
Any other questions? Autologous blood transfusion, we already in the previous presentation defined the autologous blood transfusion is the transfusion of the patient own blood. And we have 3 types of autologous blood transfusion. The first type is preoperative autologous blood transfusion. Preoperative means we have a scheduled operation for a person at a specific time. And this operation is elective. And we have a time to collect blood from this patient for reinfusion during surgery. So in this type of autologous blood transfusion, 2 to 6 units of blood can be taken from the patient over a period of days or weeks. Days or weeks. Days means when we have less units number, about 2. When we need 6 units, we need weeks for a collection from the patient. So days or weeks before surgery with concurrent iron treatment. نعوض المريض بآيرن. Criteria for autologous donor according to American Association of Blood Bank should be stable patients for surgery in which blood transfusion is likely. يعني we expect the need for blood transfusion in this surgery as orthopedics, vascular, cardiac, thoracic, and radical prostatectomy. The hemoglobin not less than 11 grams per deciliter, which is equivalent to hematocrit of 33%. We have no age or weight limits. May donate 10.5 ml per kg. ممكن ناخذ من المريض 10.5 ml per kg. Donation may be scheduled more than once a week. ممكن أكثر من مرة قلت لكم بالأسبوع. But the last should occur no less than 3 days before surgery. آخر واحد لازم أقل شيء قبل 3 أيام من يوم العملية. Autologous blood with positive viral markers commonly precluded. ما ياخذون من عنده. The contraindications, evidence of infection and risk of bacteremia. Schedule surgery to correct aortic stenosis. يعني البيشنت aortic stenosis. Patient with unstable angina. MI or CBA within 6 months of donation. Patient with significant cardiac or pulmonary diseases who have not yet been cleared for surgery by their treating physician. High-grade left main coronary artery disease, cyanotic heart disease, uncontrolled hypertension, active seizure disorder. Patient اللي has any of these criteria contraindicated for this type of autologous blood transfusion, which is a preoperative autologous blood transfusion. The efficiency of this type depends on the degree of patient's erythropoiesis. يعني البيشنت ايش قد كان يسوي erythropoiesis. Compensatory erythropoiesis is suboptimal under the standard condition. يعني بالحالة الطبيعية هو أقل من المثالي. About 1 unit per week. Expansion in RBC's volume of 11% without iron supplement. And this expansion may reach 19% with oral iron supplement. إذا نعطيه oral iron راح يصير expansion about 19%. Not sufficient to prevent anemia. معناها احنا راح يصير عندنا anemia. Result in perioperative anemia and an increased likelihood of any blood transfusion. يعني ممكن المريض يصير عنده أنيميا وممكن يحتاج blood transfusion. In aggressive autologous blood phlebotomy يعني إذا أردنا ناخذ هواية twice weekly for 3 weeks يعني راح ناخذ 6 من عنده. هنا ايش راح يصير؟ أول شيء شو وقت نبدي؟ beginning 25 to 35 days before surgery. لأن يحتاج لنا long time to collect about 6 units of blood. Endogenous erythropoietin levels increases with RBC volume expansion of 19 to 26. ليش؟ لأن هنا عندنا aggressive. الحالة الأولى كنا نحكي على non-aggressive كنا نقول 11% expansion without oral iron and 19% oral with oral iron. Here with aggressive autologous blood phlebotomy, volume expansion about RBC volume expansion about 19 to 26. This is with endogenous erythropoietin, depend on the person endogenous erythropoietin. The addition of exogenous erythropoietin therapy stimulate erythropoiesis and the RBC expansion up to 50% of RBC volume. يعني ممكن نوصل إلى 50%. But still we are suboptimal.
ممكن سؤال؟
تفضل.
الاكزوجينوس اريثروبويتين قصدك عن الايرون سبلمنت؟
لا هرمون. احنا كنا هنا نحكي على اورال ايرون. مو؟ هنا نعطي اورال ايرون. الاريثروبويتين اللي هو هرمون موجود اندوجينسلي وموجود اكسوجينس هرمون. مثل ما عندنا جروث هرمون، مثل ما عندنا تايروكسين، عندنا اريثروبويتين. فهنا هذا الاكسوجينس اريثروبويتين اذا نطيناه راح يصعد الار بي سي فوليوم اكسبانشن up to 50% in aggressive autologous donation.
واضح، شكرا.
The disadvantages of this type of blood transfusion: intensive work for identification of suitable patients, organizing appropriately timed blood donation, and storing the blood. يعني this is very heavy hard work. إنه لازم يعرفون كل بلاد مال منو، ونعرف كل patient، نسوي له schedule، بفلان يوم ناخذ منه، وبفلان يوم ناخذ منه السكند يونت، وبفلان يوم ناخذ منه الثيرد يونت، ولازم نعرف تاريخ اللي يسوي به العملية، والحفظ يكون separated from other units. بينما بالحالة الطبيعية blood group A كلها مخبوطة سوا، blood group O كلها مخبوطة سوا، ما يحتاج such extensive work. Storage life of blood 5 weeks، فمعناها عندنا limited time. This limited time lead to first limit number of units that can be donated. يعني هو مو open number of units. 2 reduces flexibility in postponement of surgery. يعني طبيب التخدير if faces some new signs, symptoms related to cardiovascular, related to respiratory system, and this patient better to be avoided, postponed. هنا البوستبونمنت راح يكون more difficult than if the patient not already scheduled for autologous blood transfusion. لأن هنا أكو heavy work يعني have been done وأكو 2 to 6 units of blood have been collected to be infused in this time of surgery. Not suitable for emergency surgery. ما نقدر نستخدم emergency. Not suitable for anemic patient or patient with ischemic heart disease or any patient with the diseases already mentioned in the contraindications for this type of autologous blood transfusion. The second type, acute normal volumic hemodilution. Acute. At the start of surgery, 1 to 2 units of blood drawn and replaced by fluid. يعني البيشنت نسحب منه 1 to 2 units ونسوي له replacement by fluid. And this one or these 2 units retransfuse at the end of operation. نهاية العملية نسوي لهم transfusion. The principle, removal of whole blood from a patient while restoring the circulating blood volume with an acellular fluid shortly before an anticipated significant surgical blood loss. Blood collected in standard blood bags containing anticoagulant stored at room temperature. يعني احنا simply we expect this operation associated with massive bleeding and patient will need blood transfusion. So if we collect whole blood from this patient and replaced by fluid, the blood already bled during surgery will be in less of original blood because this blood is already diluted with the fluid. فاحنا حافظنا على blood قبل ما يصير بيه bleeding وخلينا البلاد اللي صار بيه bleeding diluted with the fluid. سوينا له collection وحفظناه at room temperature. بعدين نسوي له re-infusion during surgery. شو وقت؟ after major blood loss has ceased or sooner. يعني بعد ما يسيطر الجراح وخلصنا من time of bleeding فاحنا نقدر نرجع نفس البلاد الى نفس المريض. Simultaneous infusion of a crystalloid 3-to-1 or colloid 1-to-1. We already talked about this fluid management in the presentation of fluid. Blood transfused in the reverse order of collection. يعني آخر واحد سحبناه من المريض أول واحد ننطيه. إيش قد نقدر ناخذ من المريض بلاد؟ Estimated blood volume. إيش قد نقدر ناخذ من المريض؟ فراح نشوف أنه البلاد الفوليوم اللي نقدر ناخذه equal to estimated blood volume. Estimated blood volume شلون نعرفه؟ equal to hematocrit original from the hematocrit الفاينل. الهيماتوكريت الاوريجينال يعني قبل ما ناخذ قبل البليدنج. الفاينل اللي وصلنا له نقسم على الهيماتوكريت الافريج اللي هو equal to original plus final divided by 2. الاستيميتد بلاد فوليوم احنا اخذناه تقريبا 65 مل بير كي جي بالادلت. ف if the patient with hematocrit originally 40 and desired يعني after taking blood from patient وصلنا الى 30 فصار عندنا 40 الاوريجينال 30 الديزاير اور الفاينل. فاذا الافريج 40 زائد 30 تقسيم 2 70 تقسيم 2 يطلع لنا 35. فصار عندنا هسه 35 الاستيميتد بلاد نعرفه 65 مل بير كي جي تطلع تقريبا 5 لتر. 5 لتر multiplied by this equation اللي consists of hematocrit original, final and average. net result راح تطلع لنا تقريبا 1.5 لتر تقريبا. يعني نقدر ناخذ من المريض 1.5 liter. This is for 70 kilogram young adult patient. It is the same of يعني هذا اللي this equation اللي من أنها نحصل ايش قد نقدر ناخذ من المريض taking blood volume taking نفسها نعتمد عليها في موضوع آخر أنه إذا عندنا مريض والمريض ده ينزف ايش قد يعني نسمح له ينزف بدون أن ننطي بلاد. maximum allowable blood loss. شلون نطلعه؟ نطلعه بنفس هاي الايكويشن بس بمكان ما نقول هنا desire راح نقول هنا final لأنه هنا desired احنا دا ناخذ this is our desire to reach 30 while here obligatory blood loss.
بس العفو استاذ اذا امكن تعيد لان الصوت قطع وراح يعني ما سمعنا هاي اخر عبارات اذا امكن.
هاي المعادله هذا الايكويشن هنا احنا ايش بدنا نحسب؟ بدنا نحسب ايش قد نقدر ناخذ من المريض دم من هاي الايكويشن. لذلك بدنا نقول estimated blood volume taking وخلينا هنا كلمه desire لان احنا according to our will نقول نريد نوصل الى hematocrit 30 وطلعت عندنا هاي الريزلت. نقدر ناخذ تقريبا 1.5 لتر تقريبا. نفس هاي الايكويشن نفسها ممكن نستخدمها في مكان ثاني اللي هو لما المريض عنده بليدنج فايش قد الماكسيمم allowable blood loss يعني ايش قد الماكسيمم allowable blood dose برا لازم نعطي بلاد. فهنا نفس هاي المعادله بس بمكان كلمه desire نسميه final. ليش؟ لانه هنا not according to our will or desire دا يصير البلاد loss وانما دا يصير because of bleeding اكو source of bleeding. فنقدر احنا نحسب الماكسيمم allowable blood loss اللي هو يطلع تقريبا 1.5 liter and after that we have to transfuse the blood for the patient. And this is one of the questions already introduced at the start of this presentation. لما ناخذ من المريض blood سواء كان type 1 or type 2 كنا بدنا نحكي على blood. فهنا what is the physiological compensatory mechanism to maintain oxygenation? Actually, this is apart from my presentation, but I added these slides for you for a revision of other presentations in the physiology of cardiovascular system and respiratory system. There is a decrease, I mean, with the bleeding or after taking blood from patient, there is a decrease in O2 carrying capacity, and this is clear for you. So there is decrease in O2 content. الأوتو كونتنت حسبنا بالمحاضرة السابقة شلون نحسبها. قلت لأنه قل الهيموغلوبين، أخذنا بلاد قل الهيموغلوبين. So there is decrease in O2 delivery. هاي النقطة الأولى. النقطة الثانية، إذا أخذنا بلاد من المريض، الviscosity decreased 50% when PCV decreased from 40 to 20. يعني theoretically إذا أخذنا نص دم المريض، فهنا الviscosity decreased by half. This decrease in viscosity lead to decrease in systemic vascular resistance, and the decrease in systemic vascular resistance lead to increased stroke volume and increased cardiac output. باي تعتبر compensatory mechanism. Also, the decrease in viscosity lead to improved blood flow to the tissue لأنه راح يكون less viscous blood، لذلك the blood flow to the tissue will be improved. The increase in cardiac output does not compensate for the decrease in O2 content. احنا هنا ايش قلنا؟ قلنا عندنا compensatory mechanism increase بالكاردياك output، وقلنا اذا اخذنا دم من المريض راح يصير عندنا decrease بالاوتو. So this increase in cardiac output does not compensate for decrease in O2 content and lead to decrease in O2 delivery. Net result راح يصير عندنا decrease بالO2 delivery. The O2 extraction ratio equal to O2 consumption over O2 delivery، اللي هي آخر شيء قلنا عليه ال O2 delivery decrease. Normally in healthy resting adult it is about 25%، حكيناها بالمحاضرة السابقة. قلنا ال O2 delivery about 1000 ml per minute. The O2 consumption about 250 ml per minute. فلذلك ال O2 extraction ratio 25%, but may increase this percent during resting adult, healthy adult. This percent increase to 70 to 80% during exercise in trained athletes. هاي ال 25 ممكن تصعد إلى 70 or 80%. O2 consumption is independent on O2 delivery due to increase in O2 extraction ratio. The O2 consumption is independent on O2 delivery. Okay. خلينا نشوف منو يجاوبنا. أمير تسمعني؟ أمير؟ حنان إبراهيم. هبة جاسم. نور عماد. عمر تسمعني؟
نعم استاذ اسمع.
ظاهر الجماعه عايفين المحاضره تعبانين.
نعم استاذ يا من
لا استاذ تكون غلط.
عمر
استاذ تقصد عمر قاسم ولا عمر صلاح؟
اوكي نو بروبلم. عمر
نعم استاذ انا عمر قاسم استاذ.
اوكي
عمر صلاح استاذ.
يلا عمر قاسم.
نعم استاذ.
عمر auto consumption is independent on auto delivery. Can you explain this?
استاذ يعني التشيو هو ياخذ الاكسجين اللي يحتاجه بغض النظر عن كميه الاكسجين اللي هي ديليفري للتشيو.
Very good. يعني هو المحاضرة السابقة قلنا ياخذ 20 ايش قد قلنا 250 مل per minute. فاحنا اذا الاوتو ديليفري مالتنا كان 1000 مل هو حياخذ 250. اذا الاوتو ديليفري 750 هو ياخذ 250. اذا الاوتو ديليفري 500 هو ياخذ شنو؟ ياخذ 200. في كل الاحوال شنو راح يتغير عندنا يا عمر؟ راح يتغير عندنا في شيء اسمه الاكستراكشن ريشيو. الاكستراكشن ريشيو هنا نورمالي 25%، بس لما الاوتو ديليفري اللي هي بالمقام تقل اذا وصلت لل 500 والاوتو كونسامشن هو 250 معناها الاكستراكشن ريشيو ايش راح تصير؟ راح تصير 50%.
بالضبط تضاعف.
I just wanted to clarify that for you all. Now, till يعني الauto consumption is independent on auto delivery till the point at which auto delivery not enough to support cellular need. يعني نوصل مرحلة الauto delivery not enough to support cellular need hypoxia. فهنا ايش راح يصير عندنا؟ راح يصير عندنا lactic acidosis. Many use auto extraction ratio of 0.5 as a transfusion trigger. يعتبرون من توصل الاكستراكشن ريشيو 0.5 هنا يقول لك المريض احنا كنا اذا تتذكرون بدنا نحكي على الفيزيولوجيكال compensation. From the auto extraction ratio point of view, when this ratio reach 0.5 يعني هي الريشيو تصعد توصل إلى 0.5 معناها هذا المريض need for blood transfusion. فحكينا بالphysiological compensation حكينا عن الauto delivery وعن الفيسكوسيتي وعن الاوتو اكستراكشن ريشيو، وهسه راح نحكي على الاوكسي هيموغلوبين ديسوسيشن كيرف اللي هو المفروض تاخذوه او اخذتوه ما اعرف بمحاضره الريسبيراتوري فيزيولوجي. At hemoglobin of 9 to 10 gram per deciliter, oxyhemoglobin curve begin to shift to the right. فلما يصير shifting to the right راح يصير decrease in the affinity of O2 and more release of oxygen from hemoglobin, and this shifting so clear at hemoglobin of 6.5 gram per deciliter due to an increase in 2,3-DPG, and this need 12 to 36 hours to be developed after blood transfusion. Now, the criteria for selection of patients for second type اللي هو acute normovolemic hemodilution of autologous blood transfusion لما يكون اكو high likelihood of transfusion يعني we expect the need for transfusion. hemoglobin more than 12, no significant diseases, absence of severe hypertension, absence of infection. Advantages of autologous normovolemic hemodilution: decrease in RBC mass lost for a given blood loss. يعني البلاد اللي نزفه المريض يحتوي أقل كمية من الار بي سيز. ليش؟ لأن احنا أصلا أخذناها ضميناها. Perceived lower relative cost compared with the preoperative autologous blood transfusion، يعني النوع الأول. Or allogenic blood transfusion، ordinary blood transfusion. Almost negligible potential for clerical errors because blood is kept in the operating theater until transfusion. يعني الأخطاء تقل هواية لأن هو بنفس المكان ينأخذ وبنفس المكان ببرا ساعة ساعتين ينطل المريض. Infectious and immunological complications associated with allogenic blood are avoided. ما راح تصير عندنا هاي complications. Platelet function and coagulation factor are preserved لأنه a matter of hours. Theoretically improved tissue oxygen delivery due to right shift of oxygen dissociation curve and reduced viscosity. Disadvantages of this type of autologous blood transfusion: greater hemodynamic instability. يعني أكثر الهيموديناميك instability. Hypovolemia is more likely. Potential complications of administration of large volumes of crystalloid. Useful only in healthy adults having surgery with substantial anticipated blood loss, who have a high preoperative hemoglobin and who can tolerate low intraoperative hemoglobin. These are the disadvantages of this type of blood transfusion. Now we're gonna talk about the third type of autologous blood transfusion, which is intraoperative autologous donation. In this type, we need device, and there are many devices used to collect the blood from wound and filter it for retransfusion. يعني البيشنت أثناء العملية يصير عنده bleeding. هذا البليدنج مو نفرش احنا التاول، واحدة من التاول بيها فد نايلون يجمع هذا البليدنج، يعني ما يوقع بالقاع ولا يروح على التاول حتى يمتص، ينجمع داخل نايلون. ينجمع نسوي له suctioning collection، بعدين نسوي له filtration from debris، ونعامله معامله بعدين processing راح نحكي عليه، نسوي له transfusion at the end of surgery. It is also called intraoperative cell salvage. The physics of cell saver: technique based on centrifugation, separating red blood cell from lighter component and the fluid, including the plasma, saline, and buffy coat. يعني ناخذ بس الار بي سي. System filled with 1 to 200 ml heparinized saline priming حتى ما يصير coagulation. Blood release at the wound site aspirated via double lumen suction catheter, 80 to 100 millimeter mercury, the pressure, suction pressure, negative pressure. Anticoagulated, blood نضيف له anticoagulant, stored in a reservoir with a filter, then pumped into rotating separating chamber, washed with 1 to 1.5 liter saline and concentrated. Optimizing red cell return, suction, rinsing of of sponge, anticoagulant, and collection reservoir. These are the main parts or steps of this process. Advantages: suitable for elective and emergency surgery. Reduce risk of administration of incorrect blood لأن نفسه ينأخذ من المريض. Process in by specific device and then re-infuse to the same person or patient. Reduced use of allogenic blood. نقلل حاجتنا للبلاد from another person. Disadvantages: no preservation of clotting factor or platelets لأن احنا قلنا بس RBC. Initial financial outlay to buy the machine and the trained staff, but the cost of disposables is less than the cost of 1 unit of blood. يعني بالبداية يحتاج أن نشتري الماشين فتكون يعني cost. Use in malignancy is controversial. Blood salvage from contaminated field is unsuitable for re-infusion. Now, I will end this presentation by we have to be aware whenever we transfuse the blood to the baby. This is number one. And number two, we have to be aware about bleeding from a baby. لأن احنا دائما اكو عندنا انطباع يعني عن الادلت bleeding، نقول quantity of bleeding، نقول كذا. فsometimes even small volume of bleeding from a baby may be indicated for blood transfusion. Why? Because the total amount of blood in the baby has about just 1 cup of blood in its body. So here, the children have higher cardiac output to blood volume ratio than adults. Estimating volume will premature 90 to 100 ml per kg, term infant to 3 months about 80 to 90, and children over than 3 months 70 ml per kg. فتخيلوا إذا واحد يعني نقول وزنه مثلا فد 6 كيلوات، 6 كيلوات، إذا نحسب على التسعين يعني معناها عنده 540 مل. هاي توتال. إذا كان أصغر بالعمر وزنه 3 كيلوات ونحسب على 100 راح تكون 300 مل. هذا توتال بلاد فوليوم. فهنا allowable blood loss راح يكون كلش قليل. فبليز be aware about the bleeding from baby and the need for blood transfusion for pediatric age group. Here the total blood, water, أخذناها بمحاضرة الفلويد. And this is the end of this presentation. Thank you very much. If you have any question or comment, I'm ready to hear.
عفوا أستاذ تسمعني؟
تفضل.
العفو أستاذ، سألتني قبل شوية ما أعرف يعني فتحت المايك بس ما لأن انستيبل صراحة الإنترنت عندي. هو بالنسبة لنفس السؤال بالنسبة للتريتمنت أوف hyperkalemia أستاذ. If there is any rule for diuretic in the treatment of hyperkalemia، هذا السؤال الأول. السؤال الثاني أستاذ بالنسبة للماكسيموم allowed blood loss، يعني إحنا بالعمليات دائما اللي عندنا متوفر هو ال HP، يعني ما عندنا هيماتوكريت. يعني نقدر نستخدم ال HP، يعني أنا شفت اللي أكثر الموجودين وياي يستخدمون ال HP بالحساب مالتها، وقسم لا يقول لك احنا نقدر نحوله مثلا الى هيماتوكريت. شكرا استاذ.
نعم، تحوله للهيماتوكريت by multiplying by 3. وبالنسبه للدايوريتيك ممكن تستخدمها ايضا بالهايبركاليميا، بس يعني يعني critical condition of hyperkalemia اللي تحتاج يعني rapid management راح يكون الإفكت of diuretic يعني delayed. بس حالات الهايبركاليميا اللي هي not so يعني urgent or emergent فتقدر تستخدم الدايوريتك.
العفو أستاذ، سؤال.
تفضل.
أولا أشكرك على تعبك المحاضرة. ثانيا سؤال أنه بالنسبة للأوتولوجوس blood we need about 1 week to collect it and then start for a week as you said 25 up to 35 days before surgery. Does this blood contain functioning platelet and other component of the blood يعني of fresh blood? Does it preferred to the fresh blood?
لا تتذكرين ببداية المحاضرة احنا قلنا ان البليتلتس بعد يومين تقريبا البلاد يكون خالي من البليتلت، ما بي بليتلت. وقلنا regarding clotting factor اذا قبل ال 14 يوم
نعم
هيكون خالي من الفايبرينوجين ومن الفاكتور 5 وبعد ال 14 يوم راح يكون خالي من معظم الكلوتينج فاكتور. فلذلك هذا يعتبر البلاد اللي احنا collected over 2 to 6 weeks راح يعتبر ما بي platelets ما بي clotting factors.
شكرا أستاذ. هو أنا هذا سؤالي أنه
هذا كلامك ده ينطبق على شنو؟ على الفيرست تايب اوف autologous blood transfusion اللي هو Preoperative autologous blood transfusion. السكند تايب لا، سكند تايب ناخذه بنفس اليوم قبل العمليه فيحتوي على بليتلت وكلوتينج فاكتور.
شكرا أستاذ.
Any question or comment?
العفو أستاذ، بالنسبة للمانجمنت أو هايبركاليميا.
نعم.
الكالسيوم.
نعم.
يعني بس ما كان واضح الصوت بوقتها. يعني أكو رول
الكالسيوم هو ننطيه not to decrease potassium level وإنما نعطيه to protect heart and prevent the heart from cardiac standstill. فاحنا نحمي الهارت، بس هي البرايورتي بالمانجمنت اوف هايبركاليميا البرايورتي تو جيف كالسيوم بعدين تقلل الليفل.
تمام اوكي شكرا.
اني other question.
استاذ اياد سؤال اذا ما تصير زحمه. بالنسبه للماكسيمال لور بلاد لوس بالنسبه للاتش بي الفاينل، يعني عندنا مثلا اتش بي معين لكل مريض نقدر نعتمد عليه لو الا يعني مثلا ديس انفستيجيشن يلا انه بداخل العمليه. يعني مثلا مريض عندنا انه الاتش بي يعني مثلا لازم ما ينزل لل10 او مثلا مريض اخر انه حاطين ببالنا مثلا لازم ما ينزل جوا ال7. ف
هو انت سمعتني يعني من حكيت قلت يعني الاوريجينال هيماتوكريت انت تسميه اتش بي مو فد مشكله.
اي نعم.
اوريجينال هيماتوكريت والتارجت مالتنا.
نعم.
التارجت مالتنا اذا تتذكر اكو بالمحاضره الاولى قلت احنا لما ينزل الاتش بي عن 6
نعطي ضاهيطي
لازم نعطي بلاد.
اي نعم.
ايش نعتبره قليل مو صحيح؟
نعم.
اذا احنا ما ننزل عن 6 اللي هي يعني ما يقارب تطلع 18 هيماتوكريت يعني تقريبا 20.
نعم ان شاء الله. شكرا جزيلا استاذ.
اكو بعد سؤال؟ بس ملاحظه اكو واحد منكم عنده فكره عن these types of autologous blood transfusion اذا اكو واحد منهم available in our country؟ Okay. Up to my knowledge اللي متوفر هو السيل سيفر الجهاز. واحنا يعني انا ما عندي احصائيه وين بالضبط موجود بكل المستشفيات، بس على الاقل متاكد انه بمدينه الطب موجود بالطابق 14 اللي هو 12 كاردياك سنتر، وبالمستشفى دار التمريض الخاص. وحسب معلوماتي بمستشفى الجملة العصبية موجود، ويجوز موجود بمستشفيات أخرى موجودة. وأنا بيرسونالي مشتغل بي سيل سيفر، مشتغل بي بالعمليات اللي هي repair of scoliosis. هاي العمليات عمليات طويلة تطول تقريبا 8 to 14 hours، والمريض يعني need massive amount and to decrease the need for exogenous blood يعني allogenic blood transfusion نستخدم this type of autologous blood transfusion، بحيث يعني most of the blood lost from the patient collected and reinfused again for the same person يعني according to need. To be oriented into انه هذا الجهاز موجود في بعض مستشفياتنا بالعراق. Regarding the first and second types of autologous blood transfusion, these two types أنا ما عندي idea إنه موجودة، إلا إذا واحد من عندكم سامع أو كذا ممكن يفيدني يقول لي موجودة. أنا ما سامع يعني حد علمي إنه ما متوفرة. Okay, thank you very much. Goodbye.
شكرا أستاذ.
شكرا جزيلا.
شكرا أستاذ، عشتي لك.
شكرا
شكرا أستاذ، عشتي لك.